Public Health, Project ECHO Cancer Survivorship August 7th session. I am the South Carolina Comprehensive Cancer Control Unit Director and today's co-facilitator, Sonia Younger. I am joined by my DPH colleagues, including clinical co-facilitator, Gloria Foster. If you're able, in the chat, please post your name, which location you're with, and where you're located. For a general overview, as a brief reminder, Project ECHO, which stands for Extension for Community Healthcare Outcomes, is a telementoring and knowledge sharing initiative that utilizes video conferencing technology to connect specialist teams with primary care providers, facilitating collaborative learning and improving the delivery of healthcare services. Today, you will have the opportunity to hear from LaShonda Pettaway-Brown with the South Carolina Office of Rural Health and Alicia Buck with the Bamberg Family Medicine on upgrading electronic health records to recognize patients undergoing cancer treatment and those in remission, and the services offered accordingly. We will do introductions at the end if there is any time remaining. As LaShonda and Alicia are presenting, please type any questions you have in chat. We will monitor those and answer the questions during the Q&A segment. Today's patient case study will be presented by Dr. Brian Orr with the MUSC Cancer Holling Center. To make sure you don't miss anything, today's session will be recorded and posted on DHEC's website at dph.sc.gov/Project ECHO. Unfortunately still, we will not be able to offer continuing education credits for this session. And now for our presentation.
We'd seen that you got in there.
I am going to, do we have any questions?
An underwater LED lamp.
We have someone, just Ian, he got it. Okay, is Liz. Alrighty, so for the introduction of our speakers, I have an introduction for LaShonda Pettaway-Brown. I was looking for one for Alicia, LaShonda, but I didn't see it. So today's presenters are LaShonda Pettaway-Brown with the South Carolina Office of Rural Health and Alicia Buck with Bamberg Family Medicine. LaShonda joined the South Carolina Office of Rural Health in 2017 and currently serves as a practice transformation consultant for the Center for Practice Transformation. In this role, she is responsible for facilitating chronic disease management and patient-centered medical home recognition for rural health clinics, private fee-for-service providers, and federally qualified health centers and hospital systems. LaShonda is also responsible for coordinating the activities of the Oral Health Progress and Equity Network, also known as OPEN, which provides technical assistance, practice assessment, change facilitation, and consultation as rural providers adapt to change. LaShonda is a patient-centered medical home content expert and a certified rural health clinic professional. Prior to her role at the South Carolina Office of Rural Health, she served as the Quality Improvement Coordinator at the Carolina Center for Medical Excellence, where she focused on the Million Hearts Initiative, Physician Quality Reporting System, Meaningful Use, and Patient-Centered Medical Home. LaShonda received her Master's in Business Administration and a Master's in Healthcare Administration from Webster University. She earned her Bachelor of Science with a specialization in Healthcare Administration from Austin Peay State University. I will now turn this presentation over to Ms. LaShonda Pettaway-Brown. LaShonda, do you want me to change the slide for you, or do you want to share and you change them yourself? You're on mute, hon. Okay, you got it. Thank you.
Currently, we don't have Alicia on. She is actually down in the Bamberg area, and she said that their internet was kind of spotty. So I just want to let everybody know.
Okay.
Okay. So my name is LaShonda. As Sonia mentioned, I am a practice transformation consultant with the South Carolina Office of Rural Health. And within the South Carolina Office of Rural Health, we were charged with comprehensive cancer to do an electronic health record enhancement cancer survivorship initiative. But before I get started to tell you about this initiative, let me give you a little information about the South Carolina Office of Rural Health. We are a nonprofit organization, and our mission is to close the gap in healthcare status between rural and urban communities. Now, with 27% of our state living in rural communities, we just want to make sure we're preserving those unique characters for rural communities without compromising or eliminating their access to critical services. With partners like DPH and federal programs and local other programs, our goal is to increase the access to good quality healthcare, improve those social determinants of health that many rural communities face, and also provide them with available resources with local needs within rural communities. Just a bird's eye view of what is housed and contained into SCORE. We have two areas. We have our provider services, where we're located, the Center for Practice Transformation, but we also focus on other things within that provider services. We focus on rural hospitals, we focus on EMS, we also do oral health, and we also focus on that rural health clinics. Under community support, we have different initiatives such as Healthy People, Healthy Carolina. We also focus on obstetrics, if I'm saying that right. We also focus on opioids, behavioral health, and we also help with network development. So we help with provider recruitment and retention. More about the Center for Practice Transformation. We have several partnerships, but the two main partnerships I'm going to talk about today is with the South Carolina Department of Health and Human Services. This is where we fully focus on the patient. Patient-Centered Medical Home, Patient-Centered Excellence Award, and also Patient-Centered Primary Care Collaboratives. We also work with the South Carolina Department of Public Health. Under the Department of Public Health, we do diabetes and heart disease. We also work with cancer prevention and control. Under the cancer prevention and control, we have several activities that we do with primary care practices, whether that be rural health clinics, federal qualified health clinics, and also independent clinics and also hospital-owned. We do program and practice level support. So we provide TA services, whether that be virtually or in person. We also do learning collaboratives where we have this shared learning environment where practices are learning from each other. We also work to improve preventive care services. So making sure practices have workflows in place to talk about breast and cervical cancer screenings. We also provide support around program monitoring and data reporting systems. Now, it was inevitable that we have this partnership with DPH and Comprehensive Cancer and the BCN program because our state is comprised of 46 counties broken up to 4 areas. Within each county, they contain rural areas. So access to medical services can be challenging for residents. So that is why this partnership is so important. We've had this partnership for 7 years. We focus on enhancing engagement with those rural areas. We try to make sure we're working collaborative with the patients, the providers. Our overall goal is to eliminate health disparities, also increase cancer screening rates, incident, and mortality. The services that we provide through BCN partnership is we help to identify that eligible population that may be eligible for services, preventive services. We also help them learn how to utilize the EHR and make sure they use it to its full capability. That includes implementing those clinical decision support tools for patients and also for the providers. We also come in and help them with their workflow analysis to ensure that they're working to the top of their license. We do process mapping, quality monitoring, and improvement. Our overall goal is to make sure practices in rural communities that work at federal qualified health centers, independent practices, also hospital-owned practices, we want to make sure they're aligned with what is coming soon, and that's value-based care. Within the EHR Enhancement Cancer Survivorship Initiative, What we wanted to do is impact cancer survivorship care in rural South Carolina. We wanted to provide direction on identifying, developing, and integrating cancer survivorship care plans within a primary care practice. Each practice that was a part of this initiative received $10,000 in technical assistance to help implement and sustain this program. Now, the scope of the work is very in depth, but I'm only going to give you highlights of the actual work that we did within that scope. The main focus is to utilize the EHR to identify cancer survivors or patients who completed cancer treatments or in the process of receiving cancer treatments. We also use that to assess and document where patients had cancer treatment, their survival plan, or if they even needed one. We wanted to make sure we were providing and documenting navigation services for the completion of the cancer survivorship plans for patients. We also wanted to make sure they completed cancer treatments and also actually making sure they come back to primary care to get their preventive services. We wanted to make sure patients know about the importance of cancer screening and the tobacco cessation programs throughout our state. We wanted to link patients with the community resources that were available for survivorship initiatives. And the overall goal, as we mentioned, is the EHR. We want to make sure providers had an alert within the EHR to identify patients who either had cancer treatment or were cancer survivors. And we want to make sure they had those care plans updated every year. The areas of impact. We recruited 3 practices, 1 federal qualified health center, 1 rural health center, and 1 free clinic. Their areas were Bamberg, Orangeburg, Barnwell, Collington, Allendale, Charleston, Berkeley, and Dorchester counties. But the one that we're going to highlight today is Bamberg Family Practice. And I'm going to push along, Sonia, if that's okay, because Alicia was not able to log in. Okay, Bamberg Family Practice is a single location. They are a rural health clinic. They have 1 MD, 4 nurse practitioners, and a clinical pharmacist. They see an average of 100 patients a day. The key to their success, their very innovative practice, is communication. They want to make sure they have workflows that meet the needs of their patients and also provide good quality care. They have a team of 34 plus people who provide administrative, clerical, clinical, and billing staff. Their future goals is to ensure they schedule meetings to make sure policies are aligned with the recommended standards of care and that their health team is all aware of the upcoming updates that may affect their practice. Bamberg implemented this program, and this is information about the demographics that were identified as either a cancer survivor, someone in cancer treatment. So they were able to pull this information based on ICD-10 codes. So they were actually tracking if patients were either cancer survivors or actually receiving cancer treatment. So they identified patients between the age of 19 to 59 and 60 and older. They also identified them by sex and ethnicity. The overall patient population affected by cancer was 86 were over the age of 60, 57% were men, and 61% were Caucasian or white. We actually supplied them with the cancer survivorship care plan, and Bamberg went in and adjusted a little bit to fit their actual patient population. And this is the actual cancer plan that they're currently using now. Total impact. They had 10 cancer survivors that were 1 year post-treatment. They had a total of 10. They had 69 patients that completed cancer treatment. They had 6 patients that were in the process of receiving cancer treatments. They had 59 patients who had a history of cancer, and that was 2 years or more post-treatment. They contacted 119 patients, and they completed 119 cancer survivorship care plans, which gave them a total completion rate of 71.3%. We all want to know about the lessons learned. Some of the barriers that this practice faced was the lack of patient medical history. Patients were not familiar with their treatment plans that were put in place. For some, it had been so long that they're not sure what actual treatments they receive, what medications. There was no process currently to identify patients. There's also was a lack of communication between the PCP and those specialty providers. So they were not closing that loop of care around the oncologist sending information back to the actual primary care without a request. The PCPs at Bamberg practice had to ask for the actual documentation. There also was a barrier around the lack of identification around the language, culture, education, and those financial barriers, those social determinants of health. Also was a barrier for them and a lot of other practices is the EHR and how to capture their data. They're currently on Athena, Aprima, which is a fairly sophisticated EHR, and they are very equipped with someone who knows how to run reports within their practice. Now, their successes, they were able to identify those gaps in care, such as those preventative services and coordination of care, because they were able to speak to their actual patients. Patients were so excited to hear from Bamberg Family Practice, just because they felt like, you know what, you're connecting with me, you're trying to see how I'm doing, and they felt that warm and fuzzy and felt like they were being cared for. So patients like that engagement outside of the actual facility. They were also able to learn how their EHR functions in reference to cancer survivorship care plans, also developing the strategy to incorporate cancer survivorship within their EHR. They also identified the potential to build on the current infrastructure to support more of that enhanced care coordination and collaboration between the patient and the interdisciplinary teams. More lessons learned. The thing that made them so successful was they had a champion to ensure the project was going to be successful. They have very clear communications on expectations in between their providers and the care teams. And they also had a systematic follow-up, starting from the front desk to the actual triage staff, to the actual providers, to the actual referral coordinators. So that was their key for sustainability. And they also was successful to ensure that providers and staff received ongoing training around cancer survivorship and those best practices to support sustainability. The overall goal in reference that we do with practices is to, as I mentioned before, move them to value. And value is the quality plus the service over the cost of care for each patient. And so the more we implement these types of initiatives, also increases the quality of care that they receive, increases the service they receive, and also reduces the cost because you're able to coordinate care and also reduce care among those specialty providers, resulting in an increase in value. The summary. The best thing about this partnership was the things that we had available for them, the opportunities we were given because of DPH, Comp Cancer, and the BCN program. We had those resources available to support the practices. We made those connections. We found out what was the biggest need in this particular community, and then we met the patients where they are. We also aligned those patient care fundamentals. We developed the messaging that support current change, making sure that the patients are activated and engaged. And that helps to align those core principles of patient care. Any questions? I'm going to share my information here. As I mentioned before, my name is LaShonda, Practice Transformation at the South Carolina Office of Rural Health. My email is located right here on the PowerPoint. You are more than welcome to follow us on Facebook, Instagram, and Twitter. We also have a newsletter that comes out once a month. It's called the Rural Focus. And if you would like to subscribe, you can always text SC Rural Health to 66866. Also, our website is scorh.net if you're interested in finding out more information about our organization.
Thank you so much, Shonda.
You're welcome. I'm sorry, I felt like I rushed through it, but if you have any questions, feel free to let me know.
Sure. We have 2 questions for you.
Okay.
Dr. Crumley, you said you'll go ahead and ask your question. You had the question in the chat, yeah. But I think you
yes.
Go ahead.
Yes. Thank you very much, Ms. Heatherway Brown. That was a very excellent presentation. One of the things that first off, I think it's a great idea to anything you can do to enhance communication between the primary care physician and the oncologist, because that can help in terms of compliance, because the oncologist may be someone who's far away and doesn't have quite the same rapport as the primary care doctor, whereas this patient would be more likely, I think, to feel that they can communicate with their primary care provider. So my question though is, what are you defining as a rural community? Because that could potentially define or capture a whole lot of populations that we may or may not think of as rural, depending on what one has in mind. In other words, is a rural community one where everyone lives on 5 acres of land and has a barn? What's a rural community?
So there's many definitions to rural. Currently, we go with one, but there's several definitions. It could be by the total population of patients based on square footage. And so the Office of Rural Health, and I don't know it read off, use only one definition of rural. But however, in many counties, even though you have, let's say, the Midlands have very rural areas within the Midlands, such as, I'm trying to think of it. It's read off of Gardens Ferry Road.
Hopkins, Eastover.
Yes. So those are considered rural communities. So those areas, even though you have Richland County, within Richland County, they're still rural communities. So I hope I was able to answer that question for you.
Well, yes, and that was exactly my point, because because I'm interested in the intersection of rural health disparities and minority disparities. And it's just, like I say, you can take an area like Hopkins that, one might say, oh, that's not rural, but yeah, it does kind of fit the catchment of rural community in most cases and in most definitions. And there is that intersection of minority health disparities as well as rural health disparities in that discussion. So thank you very much.
You're welcome. And just to let everyone know, even though we're the South Carolina Office of Rural Health, we still work with Prisma, we work with Lexington, we work with MUSC Orangeburg, we work with a lot of the large hospital systems because of the new mergers that are coming through, where you have Prisma who are buying up a lot of practices, and they're buying up rural practices in Batesburg, Leesville. So we are working with not only them, but federal qualified health centers. We are working with free clinics. Even though they have an association to support them, they still may reach out to us because we receive different funding mechanisms to support them all. And as you mentioned before, they're all impacted by rural residents.
And LaShonda, I'm like you're saying, and the different partners that we work with here at the Department of Public Health, it seems like over at USC, they will have a definition for rural health. CDC will give us a definition for rural health. BCN has a definition for rural health. That comes from CDC. So it seemingly, depending on which organization you're working with and the objective that you're trying to meet, is how you may define what rural health mean or rural area means. So,
Right.
okay, okay. And it's still interesting to learn that even within Richland County, we still have rural areas that are, defined by that definition. Okay,
Yes.
to be continued. Great question, Dr. Crumlin.
I
You
think
answered. Go ahead.
Mackenzie had a question
She sure did.
um,
Mhm.
about survivorship programs. So Bamberg is connected to Orangeburg, which is the only hospital that services that particular area. For some patients, it could be the culture of the actual hospital for the reason of them not being able or not being supported with that cancer survivorship program. So a lot of people in that particular area have this, how would I say it, stereotype of, you know what, I don't want to go to this hospital for support services. So they'll actually go to Lexington or they'll go to Richland County Prisma and won't necessarily use their hospital. So it's so many factors in which a patient may not use those support services that are connected to the hospital. It could be the culture of the hospital. It could be the culture of the actual patient. It could be those stereotypes that the patients that are located in the community. So what they do at Bamberg is try to connect them to those areas where there is support systems that may be in place. So Bamberg is run by Dr. McElhaney, and Dr. McElhaney has strong ties within the community. She's been there forever. And so she kind of knows all of the community needs. And so she's able to try to figure out how to address them. So she builds those partnerships to make sure that her patients get what they need when they need it.
Okay, excellent. Thank you. Any more questions for LaShonda? No, that was excellent, Shonda. Appreciate that presentation. As always, you bring great information, and it's been great working with you all on this project. I hope we can continue. I know we have that in the works, hopefully. Just kind of get those scope of services down packed and we can get rolling again. So thank you for all that you do. You're definitely the expert at what you're doing. So thank you so much.
Thank you.
Mm-hmm. All right, Kim, have a question? Go ahead.
Yeah,
Go ahead.
hi everybody. Excellent work. I just was curious. I know Hallie just put a couple of the cancer care plans in the chat. Which one did you all use? I know you showed a picture of your.
So we
Cancer
used
care
one
plan.
that was used by MUSC.
Okay.
Because MUSC was the actual, and I can't remember that physician's name, but she actually gave them initial instructions on, what to do when it comes to cancer patients. What things should you address? Because MUSC is kind of the godfathers of cancer survivorships. And so they actually used a care plan that was given to them from MUSC.
Okay, super. And one thing just to let you all know, from the American Cancer Society, we have a brand new partnership that we are working on with Epic. So Epic in the Cancer Center is going to now include the American Cancer Society tools and patient education that will be automatically populated. So when a patient is going through cancer, they will automatically have some of those resources that will pop up into their MyChart. It'll be easy access for the providers. So we're super excited about this, and we're already in negotiations with a second EMR. So we're really excited about that. I feel like that will be a helpful thing for all of our cancer centers. So more to come on that.
Okay. Sounds good. Thank you, Kim. And we'll talk more about how we might be able to partner and help you all promote that as well. Thank you. Appreciate that. All right. If there are no more questions, I don't see anything in the chat. Thank you for posting information, Hallie. All righty. So I am going to turn this facilitation over to Nurse Gloria Foster for our patient case study.
Good afternoon, everyone. I'd like to introduce our speaker, Dr. Orr. Dr. Orr will present today's case study. He is a gynecologic oncologist with MUSC Hollins Cancer Center and is an assistant professor at the Medical University of South Carolina. Dr. Orr is the director of gynecologic clinical trials at MUSC and serves on several NRG disease-specific committees, including the Ovarian Core Committee. His research interest is in gynecologic oncology, emphasizing clinical and population health research. Dr. Orr will present for the next 20 minutes, and afterward, you'll have the opportunity to ask questions or to post them directly in the chat during his presentation if you wish. Without further ado, Dr. Orr, the floor is yours.
Hey everybody, Brian Orr. I am at home. We're still on Debbie shutdown with the weather, so hopefully my connection's okay. Share my screen. This is my first Project Echo meeting. I think the first presentation was great, and hopefully I'm hitting the mark on this one. Can you guys see the presentation?
Yes, we can see it.
Yes, sir.
So the case study that I have is a patient that I have I actually saw her a couple weeks ago. She's I saw her in surveillance. She's doing fine now. She's a 74-year-old with a significant past medical history of breast cancer, diagnosed originally at age 48, and she presented with abdominal bloating, change in bowel habits, and urinary frequency. Her symptoms were overall mild. She was referred to GI, for which she had a normal colonoscopy. Her symptoms persisted and were progressive, so she then was referred to urology with normal cystoscopy. Another couple months went by, and she ultimately presented to emergency room with CT imaging completed and revealed ovarian mass, ascites, elevated tumor markers, all concerning for stage 3 and stage 4 ovarian cancer. In the emergency room, unfortunately, she was said, "Oh, this is a horrible cancer. You've got a handful of months to a year to live and get your affairs in order." And so she was referred to GU Oncology. It was luckily able to give her some good news. Yes, it is a life-threatening cancer diagnosis, but we do have better treatments than what I think is historically thought, and the prognosis is getting better and better each year. So treatment for ovarian cancer is with surgery and chemo. It is a highly sensitive disease with respect to the chemotherapy response. 90+% of patients will have an excellent response with chemotherapy, and around that same percentage will be cancer-free. And so even though it is a bad prognosis, we do have a initial curative intent. And so with combination of surgery and chemo, we are able to get most patients cancer-free. Unfortunately, though, most do recur within the first few years, and after that, it's not typically a curable cancer. But so she underwent a laparoscopy to see if we could resect disease at primary diagnosis, and there was just too much disease to safely remove it all. So she had chemotherapy first with neoadjuvant chemotherapy for 3 to 4 cycles. And then she did undergo a debulking surgery where we remove all visible disease, her GYN organs. She also underwent HIPEC, or heated intraperitoneal chemotherapy, where we circulate chemo throughout the abdomen for 90 minutes at 42 degrees Celsius. And then she had chemotherapy afterwards. As part of ovarian cancer, we now do germline, as well, germline meaning her genetic mutations, as well as somatic testing, so testing of the actual tumor's genetics. And she was found to be a BRCA1 mutation in her genes as well as the tumor's genes. She was then recommended to a maintenance PARP inhibitor. A PARP inhibitor is a targeted therapy that was designed essentially for the BRCA patient population. So the BRCA gene is responsible for DNA repair, and when it is faulty, it can't repair its DNA. And the PARP inhibitor, the PARP enzyme is part of the DNA repair process, and by inhibiting it, it essentially creates something called synthetic lethality. So for patients who have BRCA mutations or other mutations of the similar DNA repair pathway, these drugs are effective at not only killing cancer, but helping prevent it from coming back. And as I said, I just saw her a few weeks ago, and she's on maintenance PARP inhibitor for the last few years and is doing well, again, with that curative intent with no evidence of disease. So for the case presentation, I wanted to she's a common type of patient that we'll see, and the opportunity for one, improved prevention, earlier diagnosis, and then also highlight some optimized cancer care. So her history of a breast cancer at a young age, her persistent abdominal symptoms, and then genomic testing once cancer is diagnosed to develop an individualized therapy plan. And I'll go through each of these in the slide. So breast cancer diagnosed at a young age. Current guidelines recommend genetic testing for all breast cancer patients diagnosed at age 65 or less, testing for patients over 65 based on personal history, family history, or ancestry. This patient was also of Ashkenazi Jewish descent, and so even if she was over 65, because her diagnosis of her breast cancer was at 48, but if she was over 65, she would also qualify for this. They also recommend testing patients with recurrent disease. And so this guideline holds true for patients with a history of breast cancer. She continued to see her primary provider as well as her OBGYN. And I think there was a missed opportunity for her to maybe get genetic testing so she could have had risk-reducing surgery. Persistent abdominal symptoms. I would say the vast majority of ovarian cancer patients feel like they were mismanaged prior to ultimately getting a diagnosis. Most of them say they know their body and something was wrong for a long time, and it wasn't until that eventual CT scan, as such, they feel like their cancer care has been compromised. Typically, though, I mean, most patients don't have symptoms until they're at least stage 3 or stage 4. And so overall, I don't think that this is going to make a dramatic change in her clinical care, but more so really as a feedback from our perspective. Most patients come in quite frustrated with their workup up until that CT scan. And so I would implore any patient who has persistent progressive abdominal symptoms, especially since CT scans are not as expensive as they used to be, have a lower threshold for perhaps getting some imaging if the patient is telling you something's just not right. And then genomic testing once ovarian cancer is diagnosed, because of decreased cost and as well as targeted therapies, it's been a universal recommendation for testing since 2017 across all of our governing societies. Genetically mediated cancer incidence was previously felt to be around 5 to 10%, but with increased testing, we now believe that most ovarian cancers may be genetically related as high as 30 to 45%. Lifetime risk for ovarian cancer is 1.3% in the general population, whereas when you have the BRCA mutation, it's as high as 40 to 60%. And so these are the patient populations where we could implore more routine screenings or even risk-reducing procedures. Unfortunately, though, this testing continues to be well below the goal of universal. At this point, numbers are probably slightly higher than this, but the most recent reported numbers are 50% are tested. This is getting better, but it's definitely not universal. And unfortunately, we do see lower rates of testing for African Americans, around 26%, and lower rates of testing for our uninsured, around 23%. And then we do see lower rates in community compared to academic centers. Continued with genomic testing once ovarian cancer is diagnosed. Genetic testing used to be very cost prohibitive. Now it's covered by mostly any insurance for an ovarian cancer diagnosis. And even if you don't have insurance, the out-of-pocket costs are minimal. I think the most recent quote I had for a full 84 gene panel was about $200 if you had no insurance at all. This result can be used to recommend family members testing and prevent cancer with closer monitoring or preventative procedures, like I just mentioned. The hope one day is that genetic testing will eventually be a part of general primary care testing at a certain age threshold, whether a patient turns 35 and just gets their full panel to know, what risk-reducing procedures they have in place. I know MUSC, and I'm pretty sure Dr. Hughes is probably presented with you guys, but our South Carolina DNA program, where they're testing for the BRCA mutations, Lynch syndrome, and cholesterol mutations. I have personally done several surgeries for patients who did not have previous standards of increased risk, whether that be family history or other cancers. I've done several surgeries on patients who had Lynch syndrome or ovarian cancer. So hopefully we can improve care of cancer by prevention instead of after the fact. And then also genetics are now fully integrated into our care management. These genetic results can dramatically impact cancer's care with targeted therapies. And I'm just going to use the example that we have for ovarian, which is PARP inhibition. Probably the last 30 years, there's been very few cancer advances, but within the last 10 years, that's not just for ovarian cancer, it's for many cancers, but in the last 10 years, it has been a dramatically fast-paced process. I feel like we probably get a new drug that dramatically changes cancer care every 6 months. And it's a more individually tailored process. And so now germline testing, so the patient's own genetics, somatic testing, the tumor's genetics, and then even circulating tumor DNA, which is more of a monitoring component right now. But now when a cancer cell grows and replicates, it will release fragments of DNA that we can actually pick up with a blood test. Right now, it's part of screening and prognostic impact for patients that have cancer, but the technology is there. It just will be refined where we will eventually be able to do ctDNA tumor testing like we do, for instance. That's what Cologuard is it's just picking up circulating tumor DNA that's in the stool, but there will be blood tests that we can do for perhaps screening one day. And then the picture on the right is essentially the impact of the PARP inhibition. It's one of our most impactful drugs that essentially we started trialing in 2010, and then we had a significant results around 2014. But as you can see, the blue line is the patients who got the PARP inhibitor or the pill for the BRCA mutation population. The red line is the patients who got the placebo, and at 5 years, over 50+% had still not had a recurrence. Previously, before this, we got excited if we could only extend this line by just a couple months in an otherwise poor prognostic cancer. And there's still patients who were on this trial who have yet to recur. And so our cancer care is getting better, and it's not just cancer care, honestly. I don't know, you watch TV and you will see a commercial like, do you have moderate to severe, insert whatever blank disease they may have, whether that's Crohn's or a neurodegenerative disorder or whatever. But these drugs are changing the care for these otherwise chronic illnesses too. So I think, and we'll look back at this time frame as a pivot point in our healthcare delivery, and a lot of it has to do with some of these newer agents. And it's not just targeted genomic therapies, it's also immunotherapies, and as well as certain receptors that are on the tumor that we get a new drug indication, like I said, just every few months. So again, in summary, this is a 74-year-old female who unfortunately was diagnosed with ovarian cancer, who had long time known she had a history of breast cancer and had a missed opportunity for genetic testing as well as risk-reducing preventative surgery. I'm now seeing her daughter, and she's getting her surgery. She also was tested positive for BRCA, and she's now getting her risk-reducing surgery in October. It will take her risk of ovarian cancer from about that 40 to 60% down to less than 1%. Ovarian cancer is still a silent cancer, though most patients do feel like that when they have symptoms, they were ignored. And then, in addition to testing, most patients, whether that's based on risk or as a population risk-reducing implementation, genetic testing is also part of our precision oncology and is dramatically changing outcomes in cancer care. That's just a brief patient summary. Hopefully this opens up some questions. Happy to take the time and answer any that you may have.
Thank you, Dr. Orr. Excellent, excellent presentation on information on women who have cancers. I'd like to ask a question, if I could start the chat off. Dr. Orr, how prevalent do you think access is to research studies for women who are diagnosed with ovarian or other cervical cancers?
I think you might have frozen.
I apologize.
sorry.
It broke up a little bits and pieces of that. Maybe my connection, but do you mind repeating the question?
I'm sorry, sir. Absolutely. How prevalent is access to research studies for women who are diagnosed with ovarian or other cervical cancers at this time?
Was the question how many are diagnosed with ovarian and cervical cancers at this time?
I'm curious about the opportunity for access to research studies. You know, research studies are very, very significant in the treatment, and having participants, I mean, it's key. And so I'm just curious, since ovarian and cervical cancers tend to be diagnosed at a later phase, what do you think is being done to get the information out to clients about research studies that may be available?
I apologize. I only heard part of that question, but I do think that this is a great opportunity for research. Most GYN cancers are fairly rare, but they I think information with respect to our trials as well as diagnoses are key. Cervical cancer is a completely preventable cancer, and the areas, especially in South Carolina, that we see the highest diagnoses are in our rural areas where they either don't have access to care or limited knowledge about screening, prevention, and also vaccines. Ovarian cancer is a little bit more challenging. We don't have an identified screen that we could do to help prevent it at this time. And unfortunately, the symptoms are vague until it is an advanced cancer. Definitely an opportunity for research, absolutely.
Yes, sir. Thank you.
Yeah, hi, this is Kim Hale with the American Cancer Society, and I just put in the chat, we have a brand new research study that just kicked off in May, and it's called Voices. You can see my background. It always changes areas, but we are so excited about this project because it is the first of this magnitude. We're hoping to get 100,000 women to participate for this 30-year study so that we can truly understand all of the factors, genetics, like you just mentioned, Dr. Orr, also social determinants of health, all the things that all of us work in every single day, but it's specifically for Black African American women that we want to survey to find out their experiences in the healthcare industry, what is going on with them individually. So if you're 25 to 55 and you have not had a cancer diagnosis, the only thing that will be allowed is a basal cell scan skin cancer will not eliminate someone from participating, but they can't have a cancer diagnosis. But we would love to talk to you about this study if you or your organization would like to hear more. And then also, if any of you would like to be an ambassador for promoting this study, I would love to talk to you as well. I'll put the link in to do the ACS volunteer training. It's about a 45-minute training to learn all of the ins and outs about voices, but reach out to me. I'll put my email and I'll send you the individual link for South Carolina. And you get a swag bag of all kind of goodies if you want to be an ambassador. So that's always good. But we have something in this space that you were just mentioning, Gloria, and asking about, and very excited.
Ms. Hale, you have just made my day. This is awesome. And I definitely will reach out. Thank you.
That's great, Kim. I think Dr. Crumlin has a question.
Now, Ms. Younger, you'd be disappointed if I didn't have a question. I can.
Not at all.
Dr. Orr, thank you very much for an awesome presentation. You actually touched on one of the first questions I had, and that was whether there was any progress in routine screening for ovarian cancer. But it sounds like you're telling me that it's still pretty much a silent tumor when it finally manifests. It's usually in the late stages, but hopefully, I guess there'll be some progress with the circulating tumor DNA.
Yeah.
So yeah. So anyhow, but I do have.
I mean, so yeah, I do hope we get to a point where we do have a better assessment for catching in most screens, like catching it at pre-cancer or early stage cancers. We did do a very large international study of doing ultrasounds and a blood test called CA-125 that can be elevated in ovarian cancer, but it's not a true marker of disease activity. It's just a surrogate. And unfortunately, it didn't meet the threshold of an adequate screen. It doesn't identify patient at early stages. And so yes, we're hopeful that we can identify some other blood tests that may get us to where we can identify cancer earlier. Unfortunately, ovarian cancer, it's a surface cancer. It starts on the surface of the tube or the ovary, and then very quickly into the disease process starts to exfoliate cells into the abdomen, kind of like snow in a snow globe. And we think that time frame is actually short, probably a handful of weeks. And so it is an unmet need, but hopefully we can find some other markers, whether that's either genetic or blood tests that can get us there.
Well, good, because that's going to lead into one of my other questions was whether or not the approach, management, prognosis varies a whole lot depending on the cell type, whether it's an epithelial or stromal, or I guess the germ cells are very responsive, but I don't know whether you just group the epithelial and stromals together. And then the other question is, if you identify a young woman, let's just pick an age, under 40, who's BRCA1 positive, is there a general approach to your recommendation? Because just because she's BRCA1 positive doesn't mean that she's going to develop an ovarian cancer next week. It may even be. So anyhow, those are my two questions. Does cell type matter, and what would you recommend a young woman who's BRCA1 positive?
Cell type does matter. Everything that I discussed to this point has been for epithelial, typically high-grade serous ovarian cancer. The other types are the germ cells and even some of the stromal disease process. We are able, luckily they start inside the ovary, so they'll present with a mass that is typically stage 1, and stage 1 cancers do well. So a lot of our germ cell tumors are curable, and they're diagnosed very similar to pediatric germ cell tumors. And so they're diagnosed early stage. They just typically need surgery. Most often don't need chemo. And these are younger patients, and they typically, their fertility, we're able to spare their fertility. And then the, apologize, the second question.
Young women who are BRCA1 positive.
Oh, yes. So we know that her risk of developing ovarian cancer doesn't increase until she's at least after 35. And so current consensus guidelines are recommending consideration of removal of the tubes and ovaries after the age of 35 if they are completed with childbearing. We do have 2 currently ongoing studies evaluating. We're taking just the tube, not the ovary. As I said, we think this starts on the surface of the tube more so than the actual ovary, and we kind of lump together fallopian tube, ovarian cancer, and another one where they don't have tubes or ovaries, primary peritoneal cancer, as the same entity. These trials may tell us that these young women could have their tubes removed and not necessarily lose their ovaries, as their ovaries are beneficial for their bone health, heart health, and even we think some may play a role in some neurodegenerative diseases like Alzheimer's and dementia. And so if it's safe, we would recommend that she keep her ovaries. Now, as time goes by, that risk of ovarian cancer does start to increase dramatically in her late 30s, early 40s. And since there's not a screen, right now our formal recommendations are still to consider removing the tubes and the tubes and ovaries. Now, since 2010, when we got the evidence that we think that the cancer started in the tubes, what used to be a tubal ligation at the time of your C-section is now a complete removal of the entirety of the tube. We actually think the overall incidence of ovarian cancer, so with the patients that were in their 20s and 30s in 2010 and now, when they hit their 60s, we think the overall incidence of cancer is actually going to go down because they were removing the tubes on patients. And we do, I have a collaborative project with colorectal surgery for patients who have Lynch syndrome of also removing their tubes at the time of that surgery. And so this type of information is helping us feed into our procedures that could reduce her cancer risk ultimately. Good question.
Thank you.
Okay, so if we don't have any other questions, I don't see any other questions in the chat. Kim, thank you for all the wonderful resources. That was just so helpful. Appreciate you so much. And just a big, huge thank you to our presenters, LaShonda and Dr. Orr. You've made this session just one of our best. Yes, round of applause. You're right, Dr. Crumlin. I don't want to keep you all much longer, but if you would, please just take a moment to give us some feedback with the evaluation link that's in the chat. We are looking forward to your valuable feedback. That's how we grow and change and make things better. If you could also note on your schedule that the next session for our Project ECHO is scheduled for October 2nd, same time at 12 noon. And we would like to request any patient case studies. Again, Dr. Orr, if you want to present, we'll take you. If you want to present a patient case study, please contact me. My email address, I'll put it in the chat, is youngesm@dph.sc.gov, so we can get you ready for the next session. And that is all I have for you today. Are there any last thoughts or comments before we go? To my colleagues here at DHEC, do you feel like I've left out anything that I needed to say?
This has been a great session. Thank you so much, Sonia and everyone.
Yes,
Thank
yes,
you.
great teamwork, great teamwork. Thank you all so much. I appreciate everyone, and we hopefully will see everyone in October. Enjoy the rest of your day.
Thank you.
Bye-bye.
Bye-bye. Thank you, Dr. Orr.